Hello, everyone. My name is Stephanie. I will be talking about the maternal opioid misuse model, or the MOM model, along with my classmates who are Kate, Chris, and Janice. The MOM model is an evidence-based intervention that focuses on helping pregnant women with substance misuse. So this presentation will give you an introduction to the model, the population that the model serves, the setting of the program, behaviors, attitudes, and contexts, the underlying theories, interventions, and activities, the strengths and challenges of the MOM model, and the curriculum and other resources. Thank you.
Hello, my name is Chris, and my group did an evidence-based prevention program on the maternal opioid misuse model, which began in July 2021. I'll be talking about the setting of the program, the behaviors, the context, and the attitudes. Setting. The maternal opioid misuse MOM model addresses the needs of communities across several states, including Colorado, Indiana, Louisiana, Maine, Maryland, Missouri, New Hampshire, Tennessee, Texas, and West Virginia. While Indiana implements the model statewide, Colorado, Texas, Tennessee, and New Hampshire have partial statewide implementations. Maine and West Virginia are nearly statewide. Maryland withdrew from the model in 2022. Behaviors, attitudes, and context. Behaviors. The MOM model aims to address and reshape personal beliefs surrounding drug use and its associated stigma. Additionally, the model emphasizes the importance of raising awareness, providing education about the multifaceted nature of addiction, including its impact on family dynamics and broader societal perceptions. Attitudes. The MOM model specifically targets attitudes that attribute blame to mothers for harm to their infants. This perspective perpetuates stigma and serves as a barrier to pregnant individuals seeking necessary care, which further increases negative outcomes. Context. Its objectives include increasing awareness of the effects of opioid use during pregnancy and preventing the recurrence of opioid use. The MOM model allows for training and education to teach pregnant and postpartum women different coping skills to reduce the risk of using opioids during pregnancy. One example of the MOM model in use is in the state of Colorado, which is focusing on ways for intervention by having breakout sessions focused on peer support specialists and plans of safe care. Thank you.
Hi, my name is Kate Albers, and I will be discussing the underlying theories that informed the maternal opioid misuse model, as well as the interventions and activities that it utilizes. So first, we're going to be looking at the theories of behavioral change, first one being the health belief model. This model focuses on individuals' perceptions of the severity of a health problem, and this includes their susceptibility, as well as the benefits and barriers to changing the behavior. The MOM model includes educational and supportive services that might help women better understand the risks associated with opioid misuse, and this is during pregnancy and throughout the postpartum period, and it also outlines the benefits of treatment. We also have the trans-theoretical model, which is also known as states of change. This theory suggests that behavior change happens in stages, and the maternal opioid misuse model recognizes that women with opioid use disorder may be at different stages in their readiness or willingness to seek treatment. And this works to provide continuous care that adapts to all of these stages of readiness. Next, we will be looking at the underlying theories of substance misuse. And the first is the biopsychosocial model of addiction. This model sees substance misuse as the result of a complex interaction between biological, psychological, and social factors. And in the context of opioid misuse, this theory explains the biological factors as genetic and neurochemical imbalances, which can predispose individuals to addiction. The MOM model addresses these factors through medical treatment, such as medication-assisted treatment, also known as MAT, and that is for opioid use disorder. Regarding psychological factors, mental health issues like anxiety, depression, and trauma can drive substance misuse in pregnant women, and the MOM model integrates mental health services to treat these co-occurring disorders. Also, social factors, so the social determinants of health, such as poverty, lack of education, and unstable housing, can contribute to substance misuse as well. And the maternal opioid misuse model provides support services that address these broader societal needs in order to improve health outcomes for both women and their infants. We also have the social learning theory, which suggests that substance misuse can be learned through observing others, modeling behaviors, and the reinforcement of drug use. And this also implies that environmental and familiar factors can play a role in addiction. The MOM model incorporates aspects of social support and peer-based interventions to help pregnant and postpartum women learn healthier coping mechanisms and behaviors. So this theory is really emphasizing the positive social reinforcements through community resources and peer support networks. Next is the disease model of addiction. This one is very centralized to the MOM model because women who use substances or opioids during pregnancy are often highly stigmatized and face a lot of judgment. So this model of addiction views substance use as a chronic disease similar to diabetes or heart disease. And addiction is seen as a condition that affects brain chemistry and functioning and is requiring of long-term management. The MOM model is based on the understanding that emphasizes treatment as an ongoing process, as well as integrating medical and behavioral health care in order to treat addiction as a chronic disease rather than a moral failing or a short-term problem. Finally, we have the life course theory, and this is integrated into the MOM model because it focuses on critical periods in maternal and child health. And this is done by addressing the cumulative impact of the social determinants and trauma by supporting long-term recovery and well-being. So this is more of a holistic and multi-generational approach to support. And the MOM model seeks to improve health outcomes across the life course for both mothers and their children by breaking cycles of addiction, as well as promoting healthier trajectories for future generations. Next, we have the intervention components and activities utilized by the MOM model. First one is care coordination and case management. So this is one of the central elements of the MOM model and is used in the provision of care coordination and case management, which ensures that women receive seamless, integrated care across different services and providers. So this would include personalized care plans that are tailored to each woman's needs, care coordination teams that connect a network like case managers, social workers, recovery specialists, medical people, all together in one cohesive group. We have referral to services. So coordinators will connect women to substance treatment, mental health services, and postpartum care. We also have monitoring and follow-up. So this will ensure continuous support through regular check-ins and monitoring progress towards recovery. Next is the medication-assisted treatment, and this is integrated into the MOM model. And the goal is to use MAT to support the health and recovery of both the mother and the infant. And this is used to reduce opioid-related harm and improve long-term outcomes. So this includes medications like buprenorphine, naltrexone, and naloxone, and this is to stabilize pregnant women and support their recovery. The MOM model also supports behavioral and mental health services and provides referrals to pregnant women. And this is to address co-occurring mental health conditions that we discussed previously, so depression, anxiety, and trauma-related disorders. So these are integrated by the MOM model into mental health services, into maternal care through offering counseling and therapy. So this provides access to individual, group, and family counseling. They also take a trauma-informed care approach. So this recognizes the role that past trauma plays in substance use. It also emphasizes peer support. This is one of the activities also that the MOM model provides. So they offer group prenatal care sessions and also peer recovery coaches who have lived experience and can provide emotional and practical support for pregnant women. Finally, we have education and health literacy. So the MOM model prioritizes education, educating women about opioid use disorder during pregnancy, as well as its impact on postpartum health. And this is done through health literacy initiatives. So we have information is shared on the risks and benefits of treatment, including MAT, and also the importance of continuing care throughout pregnancy and postpartum. The MOM model also offers prenatal and parenting education. So these are classes or resources on maternal health, infant care, breastfeeding, and child development. And these serve to empower women in making informed decisions about their own and their baby's health. We also have harm reduction strategies, and this is providing information on harm reduction techniques in order to minimize risk of opioid addiction. So this would include safe injection practices and overdose prevention. And this is for women who are not yet ready for abstinence. The MOM model really is more of almost a go-between, and it directs mothers to better resources and provides them with the tools that they need to care for their own health as well as their infant's health.
So the strengths of the mom model first include that it improves maternal and fetal health outcomes. So the mom model addresses opioid dependency, and so it can improve maternal health outcomes. So it reduces the risk of overdose. There's better nutrition for mother and child, and as well as mental health management. The comprehensive support services is also another strength. The mom intervention incorporates multidisciplinary approach to the intervention, which includes counseling, mental health services, and social support. This holistic care model can improve long-term recovery outcomes for both mothers and the baby. So also another strength, is the upfront cost of implementing the comprehensive mom programs can be high. Studies suggest that long-term and benefits outweigh the cost. So the cost of implementing the model includes medications, counselings, and monitoring, which can be high, but the studies suggest that long-term, the economic benefits outweigh the cost. So this includes healthcare expenditures related to complications of opioid misuse, and then the societal cost of opioid addiction. So if we look at the challenges of the mom model, we can find that it struggles with effectiveness with diverse populations, or I should say there's limited resources on how well the mom model works across diverse racial, ethnic, and socioeconomic groups. And each cultural background or population may be impacted by the intervention differently. So it may impact their adherence to treatment. And there also are things such as language or communication barriers that come into play. Another challenge is long-term stability of the intervention. Without ongoing funding and policy support, programs may experience interruptions, which obviously can disrupt the care for mothers and babies, and also resources and financial constraints. The mom model requires significant resources, including access to medical assisted treatment, which comes along with trained healthcare providers, and also the need for social services and case management. And for some reason, regions, especially in rural or low-income areas, these resources may be insufficient, making it difficult to implement the intervention effectively.
Hello, everyone. My name is Janice Pollard, and my section is Curriculum and Resources. So that section reads, where can someone get the curriculum and other resources for implementing the intervention, including training for practitioners and community stakeholders? So where someone can get the information from would be through state Medicaid agencies that they could call, and the number on the back of their medical insurance card, and just ask about it. And of course, in one of the 10 states, or in all of the 10 states that has this model. Frontline providers, so that's people working in social services or community service boards. And that's typically where training for practitioners and community stakeholders would happen for the MOM model, because it's typically given or used in those types of settings. And then also someone can get resources from healthcare systems. So that's the hospital or a primary care physician. So if someone's going in and they have a conversation with the doctor or nurse or social worker, and they discuss opioid usage while being pregnant, then this could be information given there. I also wanted to touch on funding. So as mentioned earlier, 70% of people who participate in the MOM model, it's billed to Medicaid. but I just wanted to point out that it's built under physical and behavioral health care services. And I also wanted to just touch on some of the resources that would be like included. So like it's comprehensive care management, which is has a coordinated and holistic approach, basically physical, mental, and social. And then care coordination and health promotion. So prenatal care, mental health care, well woman care, and opioid use disorder care, which is also known as OUD. Individual and family support, so infant care, including neonatal intensive care unit stays. So sometimes, depending on how bad the usage is, with opioids, the infant can have serious birth defects or like it could be internal and external. Like internal could be organs not working right. External could be like cuts on their skins and stuff like that. Um, so that's support being provided, and then also just care for other kids. Oftentimes, the parent does not have just one child, and so they look into other resources to help the family. And then OUD support for other family members. So, like people who, like sometimes couples may like the pregnant person may have, have the opioid usage, but their partner may also as well. So, while that person is away trying to find resources for the spouse or the partner to also get some assistance. And then regarding referrals, so community and social, so like some referrals can be housing, food, like food pantries or neighborhood refrigerators, transportation, how to get to and from appointments, to and from groups, to and from um, sessions with the MOM, and etc. All right. So that's the end of our presentation. Thank you for watching. And we also have some resources listed here. And again, thanks for watching. Have a good night.